Hello and welcome to the pIBD Digest, our third episode. I'm your host, Dr. Tracy Coelho, pediatric gastroenterologist, Children's Hospital, Southampton. My co-host, Dr. Chris Bakewell, is now back from the annual BSPGHAN Conference in Newcastle. Chris, welcome back. Did you have a great time, or are you still in the recovery mode from all that intense networking at the gala evening?
It's a pleasure to be here. No, I'm fully recovered now, back into the swing of things. Thank you.
I suppose you have returned with brilliant insights and fresh perspectives on the IBD landscape. So, are we in for a full-on regurgitation?
I hope not. I think this was designed to be more of a recap of some of the important points rather than too much of the basic science, and hopefully not too much recap of my moves on the dance floor.
Maybe I should let you off this time. Chris, as you may recall, we had planned to record our third episode straight from the venue in Newcastle the following morning of the gala evening, but unfortunately that didn't happen. Now, purely by coincidence, you lost your voice after the evening. You said probably it was some virus. So as your co-host, I feel fully entitled to ask you, was it the tequila virus, the Bacardi virus, or the brewed coronavirus that conveniently comes in a pint?
Probably somewhere between the three of them, I'd imagine. No. It was a teetotal event, and very civilized. I think some bad eggs were definitely engaging in some things, but not me. No.
Chris, are you sure?
Yes.
Well, I'm a bit suspicious. I'm yet to hear back from my undercover spies from Southampton. Either they have gone very deep undercover, or they have been lured away suspiciously, or intercepted by a deadly combo of those viruses that I asked you about. Anyway, I will get to know very soon. Okay, so Chris, what's the vibe today? Are we just having a casual chit-chat about the conference, or are we heading straight onto the science talks from the IBD session?
No, I thought the series has quite a lot of scientific content in it, and we've got a few things coming up that are much more science-based. So this was more of I suppose, if you haven't been lucky enough to be able to go to the conference, or perhaps you didn't manage to go to all the IBD talks, maybe picking out some of the more poignant or clinically relevant talks for the people that can take that back to their centres and use it effectively, I think.
Yeah, I think that sounds great. I was one of those unlucky ones who couldn't attend the conference. But anyway, so sounds like we have got a whole buffet of topics to dive into. Should we just crack on and tackle them one by one?
Yes, let's.
Oh, by the way, Chris, you'll be pleased to know that I managed to wrangle our legendary colleague, Dr. James Ashton, back onto the show as a special guest. How about that?
Waiting in the wings.
Okay, so let's explore what's in store, welcoming Dr. James Ashton back on the show. James, really delighted to have you back.
Thanks so much for having me, guys. It's an incredible honor.
Should we ask James about his exploits, or should we?
I was right there with you, just drinking the mint teas. That was it.
In the trenches.
Oh yes, absolutely. I'm sure it was the mint tea that gave you the electrifying confidence to moonwalk across the dance floor. Something like a caffeine-fueled Michael Jackson. James, I have seen the footage already. Anyway, James, at this point, with your endless pIBD wisdom, you have been forcefully enrolled in a frequent flyer program. But don't worry, no actual flying involved. We know how much you love flying. Just a lifetime supply of podcast invites. We might even throw a shiny medal or a free coffee, flat white with oat milk. Is that correct?
That's completely correct, Tracy. You know me well. I see you know your flat whites well.
I do. Or, because you're on the same rota as me, I could even offer to do a free on-call for you. How about that?
I mean, that would be above and beyond. I think I'll just take the oat flat white. I couldn't take away a on-call shift from me.
All right. So, James, if you remember, for the last podcast, you got a royal introduction. Well deserved, of course. And I can sense that you are still sparkling from the glorious tributes you had from last week. Now, would you like a repeat of those moments of accolades, or would you like to remind our readers professionally who you are?
I think I couldn't take another royal welcome. I think you need to save the budget for future guests. But yeah, I'm very happy to be back. I'm a pediatric gastroenterologist down in Southampton, associate professor at the University of Southampton, and got an interest, I guess, in the more scientific aspects of inflammatory bowel disease. But hopefully, as we've been talking about, we can cover some of the things that were at the conference with an interesting spin, and provide some interesting content.
I'm sure we will. As we do not have the luxury of time and there's plenty to talk about, shall we roll?
Let's go.
Yeah, who would like to go first?
Oh, I think professors have to come before trainees.
I don't know about that.
Okay. James, off you go then.
So I was going to talk about a few different things, but maybe the first one is, given that the meeting was up in Newcastle, and there's a really strong unit for immunology up in Newcastle. The first paper is really, or the first paper and presentation I think be interesting to cover would be about IL-10 neutralizing antibodies. Now that sounds very scientific, so I think sort of taking it step by step is probably a good idea. But this is really a sort of a seminal publication that was in the New England Journal of Medicine last year, and led by teams in Newcastle, Oxford and Cambridge, about a young girl who presented with a condition which very much looks like IL-10 or IL-10RA or IL-10RB deficiency. So these are three types of monogenic forms of inflammatory bowel disease that typically present when kids are infants, with severe colitis, sometimes additional extraintestinal manifestations.
So, James, can I remind our listeners that IL-10RA, RB are IL-10 receptors?
Yes, please do remind them of that.
That reminds me, back in those days during my PhD, I wrestled, not so zealously I must say, with the immunological assays, including IL-10. I had to bombard those receptors with specific ligands, and I can tell you, so much head scratching, so many flashbacks. I think I must have just unlocked a suppressed lab trauma. Anyway, I'll move on. So IL-10 is an anti-inflammatory cytokine. What we say, a good guy in the full mix of cytokines. So IL-10 binds to receptors on the cells, which are RA, RB.
Yeah, exactly right. So yeah, I think it's really important to say that this is sort of a master immune regulator, anti-inflammatory cytokine signaling. So when you don't have that, you tend to get inflammation or uncontrolled inflammation, which is what you see in this type of monogenic inflammatory bowel disease. And I think the interesting thing from this study that was presented by Sophie Hambleton, who's one of the professors of immunology up in Newcastle, is that they had this child who presented with very much a syndrome that looked like IL-10 or IL-10 receptor alpha, receptor beta deficiency, but there were no genetic problems identified. And after a lot of immune profiling and interesting additional functional work, it was identified that this child had IL-10 neutralizing antibodies, so something produced by their B cells, so another part of your immune system that was neutralizing, stopping the IL-10 cascade working. So what they were in essence getting was a sort of functional IL-10 deficiency, what would be called, or what was sort of colloquially known as a phenocopy, so a copy of the genetic problem. And I think this is really, really interesting, because not only did they identify it in that child, they then went on to assess multiple other children and found it in a child who had older onset inflammatory bowel disease. And I'm also party to the knowledge that they've done that in a lot more, hundreds of other samples, and have found additional cases, which is going to be published, I think, some point this year. So I think this is a really sort of a change of tack from a sort of IBD pathogenesis perspective, is that we're identifying or conditions that look like genetic problems are being identified, but they're not actually caused by primary genetic problems. They're caused by this sort of functional deficit, in this case in IL-10, but there are also other potential functional deficits that may be identified in the future. So yeah, really interesting study. Has some treatment implications as well, which I can talk about, but I realize I've been monologuing for a while.
Oh no, it's an excellent monologue. So can I just to summarize, so you have IL-10, which is an anti-inflammatory cytokine, and then you have the receptors. But in this child, instead of having genetic problems with the IL-10 cytokine itself, protein, or the receptors, in this child, there was production of neutralizing antibodies, which then prevent the IL-10 from binding and carrying on the normal function of IL-10. Is that a summary?
Exactly right. Yeah, exactly that.
Okay. Can I ask, why did they decide to do these these antibodies? Was there a reason, or?
I think I don't know formally, but I mean, the index of suspicion must have been very high that this was an IL-10 problem. The case, when you read the case in a paper, looks very much like that. So I guess it's a step in assessing as to whether there is anything else that's causing it. And I think of interest, it probably opens up another avenue of when you have these cases that you can't resolve genetically, looking for other causes that might be created by the adaptive immune system. In terms of treatment, it's really interesting because you have the ability, so your antibodies are produced by B cells, or which might expand to plasma cells, and I think really interestingly, you have the opportunity to treat or to deplete B cells with a treatment called rituximab, and so you can deplete the B cells, which prevent those IL-10 antibodies being formed, which is what they did for this patient, and then they've gone into sort of a long-term stable remission with minimal ongoing immunosuppressions, and so this is potentially an opportunity to not only identify a novel condition, but treat it in a novel way, give that child or potentially in the future other children or adults a sort of personalized treatment that just treats their precise cause of getting IBD. So I think, yeah, it's a really, really interesting study. It's incredibly novel, and I think it opens avenues to future interest, really.
Yeah, that's brilliant. And James, was this a very young child with refractory IBD?
Yeah, so this was an infantile onset, so very young. I think they were a few months old. So yeah, but they did also identify an older child in the publication. I don't think that was discussed so much in the presentation, but one about 4 years old as well.
So, and can I ask, so in this child, they used rituximab to block the B cells from producing antibodies, so anti-CD20, if I correctly remember. And for how long did they continue giving it?
So I think they only gave it to deplete once, and then it sort of ameliorated the effect of those IL-10 antibodies. They could see the titers reducing, and I think their child actually is on long-term anti-TNF therapy. But compared to that's controlling the disease, whereas compared to where it was before, which is extremely uncontrolled refractory disease, it's sort of a complete step change in the treatment. So yeah, really impressive.
I agree, really impressive. So taking it further, do you think this dimension to our understanding, will it have implications in the near future, such as potentially screening a high-risk group such as infantile IBD or very early onset IBD?
That's a good question, Tracy. I think probably the first instance will be to screen genetically, and then I guess for those who have very high index of suspicion, you might go on to do more specific functional work. I think that one question is whether this case was anti-IL-10 antibodies, whether there are going to be other cases where you get other anti cytokine, or I guess in this context, sort of anti-inflammatory cytokines, so things that target those that might also occur, and there is precedent for that for other sort of autoimmune type conditions, but not so much in inflammatory bowel disease. So yeah, I think it probably opens up another line of testing, but the first line will remain genetic screening, I think. Okay,
and with your research hat on, what do you think the landscape looks like in the future in terms of further unraveling IL-10 neutralizing antibodies? What sort of greater is there a broader scope for research on this subject?
Yeah, so I can speak a little. So we're working with one of the teams in Oxford to send serum samples, or plasma samples, to see whether screening a wider population, not necessarily just early onset inflammatory bowel disease, but a wider population, would be sort of a useful endeavour. So I think this is definitely in its infancy in terms of the sort of investigation of anti-IL-10 antibodies in inflammatory bowel disease, and I know that there are other phenotypes that have been associated. So yeah, I think watch this space. There's going to be more on this coming in the next year or so, and it may become a sort of interesting avenue for both molecular diagnosis, but also maybe in terms of treatment going forward.
So that sounds very fascinating, and sounds like keen researchers like yourself have already got their feet dug deep into this hot topic. Good luck.
Definitely. Thanks very much.
While James has been passionately talking about IL-10, my co-host Chris has gone completely silent. Either he is utterly mesmerized by the science, or possibly the long day shift he's just finished has knocked him so hard that he's power napping with his eyes open.
Yeah, the quietest you'll find me is when James starts talking about a lot of science and my cogs are turning trying to ask an intelligent question. I sort of power down, just listen to him speak. No, I have nothing interesting or poignant to add or to question about James's points. I was going to ask, in terms of cases where there has been an obvious or a phenotype which seems to have a genetic component, and then you've gone to screen in these patients and haven't found anything, is there then an element of review of certain cases that have already presented themselves to go back and look for this kind of phenomenon? And I suppose adding to that, if IL-10 can be neutralized by an antibody in that as a wider phenomenon, could there be more IBD related, early onset IBD, which is, caused or contributed to by that kind of neutralizing phenomenon?
Yeah, I think that's two really good points. So the first, I guess, is that the diagnostic rate from genomic medicine screening, specifically for early onset inflammatory bowel disease, is fairly low from a genetic perspective. So yeah, there's definitely room for those very early onset cases that maybe have a specific phenotype but no genetic diagnosis to be reviewed. And the second point you make, I think, is also super valid, that whilst we're identifying these anti-IL-10 antibodies, why it's by far and away not the only anti-inflammatory cytokine that is present, and so why wouldn't other things that are implicated in inflammatory bowel disease in terms of cytokine signaling as a regulatory sort of fashion, so not necessarily just cytokines, potentially like receptors as well, and maybe specific drivers of sort of regulatory T cells. Why wouldn't antibodies against those also be implicated? So yeah, I think there's lots and lots of sort of interesting functional work that could be done here. Definitely.
Yeah, and I also find it very intriguing because these are kids who are very young, and to develop neutralizing antibodies de novo, it's all very mysterious and elusive.
Yeah, I think whilst this is a sort of functional defect, as in it's an antibody that the obviously the child is producing, there must be some sort of genetic predisposition, would be my feeling. Whether that maybe that's in the HLA complex or another area of the genetic landscape of these kids, but I think there must be something predisposing, because it's a very unusual presentation.
I think we should now retire from this IL-10 discussion for now and move on to something that is immunologically less intense.
I think so.
Yeah. Hey, look, should we get a bit more clinical? I couldn't even imagine, yeah, talking in such expert level on such a topic. But so when we came up with the concept of the episode, we thought we'd pick out some of our favorite themes or things that we picked out that were quite useful to us. And I suppose, going back through the program and having sat through a lot of the IBD lectures, one of the things that I picked out was how interesting it was that so many adult gastroenterologists were invited to talk at the meeting, which I think is a really positive thing. I think what that probably shows is that we're learning a lot from what our colleagues are doing above 16, above 18. Our patients do. Obviously, the vast majority of them would reach that age and go on to adult care, and looking at what their studies are currently or have been showing us for some time. And the one I picked out was there was an interesting talk on new frontiers in acute severe colitis. It was by a doctor up in Great Western Hospital in Edinburgh called Dr Shahida Din. And she presented sort of a lay of the land, a review of acute severe colitis guidelines and what's coming out in the near future from in terms of guidelines for the management of acute severe colitis. But specifically, the thing that stuck out for me, and James and I had a chat about this after she gave the lecture, was the recent publication in Lancet Gastroenterology, where they reported the PREDICT UC trial. And I know that's something that, Tracy, you're aware of, because what they looked at was whether in acute severe colitis, specifically steroid-resistant acute severe colitis, whether infliximab at a higher dose or at an escalated interval showed any benefit from standard treatment. And now, if you were to ask me that prior to the BSPGHAN meeting, I would have said, yep, definitely. I think we've seen that in our cohorts. Infliximab, if you escalate the dose, or rather as a standard, I would think that escalating the dose would be a good idea. That is not giving 5 per kilo, but 10 per kilo, and maybe considering bringing forward the next dose interval. I would have said it was pretty good and not many downsides. What the PREDICT UC study demonstrated was actually in their cohort, admittedly in adult patients, of 138, there's nearly 140 patients, was that there isn't a difference. If infliximab is going to work, it's a great drug and it works really well. But what it doesn't do is work better if you give more of the drug at each dose, or if you bring the schedule forward, so you're giving it more regularly. It doesn't seem to have any clinical impact in any of the assessment they made. And I think that's just really a really nice way of representing probably what is happening a lot at the moment, is this, I guess, review of our management and assessment of how we best use these biological treatments, and not going by anecdotal evidence or single center evidence, but looking at the data and saying how we should use these drugs better. And Anthony Thangarajan gave us a really nice talk on our previous podcast about all these new biologics that we have. But here we're learning something about the biologics that we've had for a long time and how to use them better. And I just thought that was a nice way to summarize that evidence.
That's great. A very good refresher. Now, can I ask, for this study, what was the outcome measure or the primary endpoint?
You'll have to excuse my pronunciation, but they've used the primary endpoint as response by day 7, and what they've used is clinical response or change in the Lichtiger score from baseline to day 7 was their primary outcome.
Yeah, just coming back to your point about the scores. As you know, in the adult IBD world, they use scores which are either immune to us or new to us. Yeah, sorry, carry on.
Sorry, just to add, the other thing they looked at was safety, and the safety profile looked excellent. Just to kind of add into that study, that is an important outcome, and was, one of the things that they really emphasized in that study was that there would seem to be no significant clinical adverse events.
Okay, so this was a subset of patients with acute severe colitis, but it didn't cover patients just in general who present with colitis, I suppose, yeah?
No, this is very specifically talking about acute severe colitis, and more specific than that, patients that aren't responding to steroids, which of course a lot of patients will and may not even need infliximab treatment.
Chris, if you recall from your time with us in Southampton, which is only a month ago, we had changed a practice of giving 5 milligrams per kg induction treatment with infliximab to 10 milligrams per kg. Now, this is not just for acute severe colitis, but for any patient with IBD, Crohn's or colitis needing infliximab. We would then review their trough levels and tailor their doses accordingly. And this approach was based on the outcomes of the PANS study and evidence from elsewhere. Now, considering the information from this particular study, will you implement a change in your practice?
So I think the missing part of that, I suppose, is what is a normal level. I think that's a really important aspect of it. I'm not sure it's hugely identified or hugely understood in every context what you're aiming for. But again, this is something that we talked about in the previous podcast, that proactive monitoring, and maybe even, before fourth dose is in the standard guidance, finding ways to identify the early responders is probably the best way to do it, rather than having a one size fits all. So, although precision medicine is a buzzword, that is what you're talking about. You're saying, as an individual, do you respond by day 3 or by day 7? If you're partially responding, why are you partially responding? Can you measure something about that patient or that response, whether that's a trough level or something else, and then tailor the next 7 days or the next month as to what you need? And some of these patients ultimately will go on to have a colectomy. And how do you know who those patients are early on? And how do you know the patient that's going to be spared a colectomy and go on to have complete remission? And I don't know how to answer that question, and I'm sure there are people that have a much, much, much better idea of answering that. Even there are 2 other people probably on this call, but I think what I'm feeling in my mind is, in the next 5 to 10 years, that's really where you need to go, is how do you personalize the medicine for the patient rather than cohorting them together in some way.
I think, Chris, you're underselling yourself. I was planning to shower some accolades with your wisdom in IBD. Anyway, can I ask, with regards to the study that you were discussing, did they do trough levels in those 7-day period, or did they have the privilege of having an in-house TDM, therapeutic drug monitoring?
I'm not sure whether they did it in the first 7-day period. I think one of the challenges, and I'm not sure what they have access to out in Australia, but one of the challenges with using that precision medicine approach and really closely monitoring the use of anti-TNF is getting those levels back quickly. Because if you do a level on day 3 or day 7 prior to giving the next dose, if you're escalating rapidly, and then you get the trough level or the anti-drug, the TNF level back in a week or 2 weeks, then it's absolutely useless for that initial period. So I think that's a really important point that you kind of picked up on, that one of the things that you can do to I guess rapidly advance this process is to get things like point of care biologic testing, so point of care infliximab level testing or adalimumab or whatever you're using, so that you can then have the ability to, if you want to, tailor treatment a little more closely or study that a little bit more closely in your patient cohort. But I know it's something that we thought about doing and are hopeful to do in Southampton. It's just about the practicalities of that and the cost and I suppose making sure it's a reliable level to make it worthwhile.
One interesting thing to discuss might be about targeting trough levels, like you said, and Tracy, you've already mentioned PANSS data there, and that 3-year follow-up is sort of the best predictor of maintaining patients on anti-TNF after 3 years, was a sort of a drug level that was between 6 and 10 at week 14, or that might not be the best, but it was a good predictor. And so we know what roughly we should be targeting. I guess what that maybe misses is it those patients that respond well, that have a slightly higher drug level, that have their disease driven by an anti-TNF process that can be identified at that early stage. Whereas if you're never going to respond, maybe you're trying to drive higher levels in that first stage, maybe your drug's being cleared much more efficiently, maybe you've developed anti-drug antibodies at a really early stage and therefore your levels are low. So I think there's lots of stuff to do with drugs that have been around for a long time. And I know, Tracy, you're a big fan of, and generally we're a big fan of thiopurines and azathioprine. I think that these drugs are really effective, right? But we just don't necessarily use them to their maximal efficacy because we don't know exactly what we're doing, despite there being quite a lot of data out there. So I think it's an interesting thing to develop as well.
Guys, I think we have to gallop through some of the discussions and some of the questions. So should we move on to the next topic? I heard and I saw some pictures on WhatsApp of our dear friend, Mr. Mick Cullen. I think he gave a talk as well.
Mick gave a brilliant talk, actually. So he's one of our gastro clinical nurse specialists I'm no longer there, but in Southampton. And he presented some really nice data of a study that you did in Southampton, where essentially looked at the evidence for the use of pre-medication in infliximab infusions. And actually, there didn't seem to be any reason to be giving the pre-medication from the literature. And so over, I think it was a 2-month period, they stopped giving the pre-medication and then audited or analyzed the effects of that in the 2 months after it. And what they found was there was no safety signal. There was no patients that seemed to have significant or any adverse events as a result of dropping the pre-medication. And then positively, there was a huge response from the patients and their families that said, actually, this is much, much better. The loss of the Piriton made them be less sleepy. There's less things that are being infused on the day. In a way, it might speed things up, reduce the amount of time you have to spend overall in the daycare ward. And for such a simple thing, I suppose, and such an easy win, it just felt like a very nice thing to present to an audience that, as a show of hands, still around a quarter of people, maybe even a half, were still giving in their centres. So I thought, yeah, it's good that you brought it up, because I think that's such a nice representation of how you can make small changes, not changing what biologic you give, but just changing the way that you give it to massively improve patient quality of life, which ultimately is as significant endpoint as any.
No, I agree. I'm really glad we are moving away from this business of pre-medication. And I don't think there's any evidence to support its benefits. It would just leave our kids so groggy, so much of lethargy, they would just not go to school. I'm really glad we have kind of moved away from this practice.
And James, as someone that you had a significant part in that study, I think, is there anything you wanted to add to that?
Well, I think there's two things for me. I think the first, the credit really needs to go to Mick, as it's sort of his initiative and talking to patients about the way they experienced it was a really, really good sort of AHP, allied health professional led bit of research, which I think is really important. The second thing, I think, the point about how the patients don't just feel on the day, but in the days after the infusion as well, is really, really important. So most of our patients will be due to go to school the day after their infusion, and I guess anecdotally, and maybe from the evidence that Mick gathered, actually a lot of them weren't able to do that, potentially because of the effects of the antihistamine, or at least potentially the effects of the pre-meds. And if we can sort of reduce those effects by stopping giving the pre-meds and get kids to school the day after their infusion, so they're missing less school, that's got to be a good thing, because we know that these kids we force them to miss quite a lot of school with their appointments and their infusions and things anyway. So I think it's as you say, Chris, it's a relatively straightforward idea, but it's an absolute win in terms of providing good sort of holistic care for these families.
Thank you both for this very productive and engaging discussion on the hot topics in pIBD from BSPGHAN. But I'm sure there are lots of other things on the horizon that we haven't touched upon. But I think it's time that we wrap it up here before our listeners drift into a snooze mode and start dreaming about more interesting podcasts. So thank you, James, and thank you, Chris. But before I sign off, I've got my poem ready for a recital. The poem, The Disgruntled Delegate. Now, this is a fictional lament of a weary and skeptical conference attendee. This does not reflect my personal views at all. Listeners, please note that this is a light-hearted take on the conference experience of this fictional delegate and is not intended to offend anyone. So here I go, the disgruntled delegate. Conferences that all learned folks attend, enamored of the wisdom and prowess of the insightful yet didactic hand, so frequently and repeatedly ushered onto the grandstand. Brilliant minds, but always are they really though? Or is it mounds of banal data reciting bizarre acronyms of studies galore? Impressive sometimes, but pour in confusion all the more. And honestly, to us humble lot of a modest academic score, do these really throw in practice wisdom of the real world on the shop floor? And about the pesky questioners of the not-so-obscure bunch, why such indulgence in endless curiosity devoid of any meaningful punch, especially when desperate hungry bellies are howling in wild for the waft of lunch? But nevertheless, conferences are such great fun to be. Warm hugs from a good old friend, mentors or ex-buddies that we so rarely see, and not forgetting the 3 whole days of peace and recharge, all so blissfully childcare free. Thank you very much. Dear delightful listeners, thank you for joining. See you for the next episode. Goodbye.